Good morning, guys, once again. So, we have already finished our topics of general surgery and breast. So, from today, we will start with the thyroid surgery. So, first of all, what you need to remember is thyroid is a butterfly gland, and usually they ask about the anatomy. What is the arterial supply? What is the venous supply? What are the nerves supplying thyroid gland? How will you perform the surgery? What investigation will you do? How will you perform the thyroid surgery? What will be the complication? This is the basic question they ask in the FMG. So let's start. So in the arterial component, you have to remember it is superior thyroid artery and inferior thyroid artery. And in nerve, you have to remember external laryngeal nerve and recurrent laryngeal nerve. External laryngeal nerve is a branch of superior laryngeal nerve. So what do you have to remember about the artery which is superior thyroid artery is you have to ligate it close to the gland. Why? Because you do not want to injure external laryngeal nerve. Why you don't want to damage this nerve? Because it supplies cricothyroid. It is a tensor of vocal cords. So this is the muscle which is used for speaking. So if there is any injury to that, it will cause adductor palsy. Okay, adductor palsy, and it will have the clinical features of aphonia, aspiration pneumonia. Now the second artery is inferior thyroid artery. This is the only artery which supplies parathyroid gland also. So if you have to ligate it, you have to ligate it close to the capsule, because you do not want to damage the extravasculature of parathyroid gland, because it can cause necrosis of parathyroid also. That is the reason you have to ligate it close to the capsule. Okay, now this arterial is done. Regarding the nerve, the another one is recurrent laryngeal nerve. If you damage recurrent laryngeal nerve, it will cause abductor palsy. If there is abductor palsy, what will happen? The vocal cords will remain closed. That is the reason you cannot remove ET tube. If you remove ET tube, then the person will have cyanosis. Okay, what is the most common site of the damage? It is near the Paris ligament. Now, what is the venous drainage? Drainage is superior thyroid vein, middle thyroid vein, inferior thyroid vein. What you have to remember is middle thyroid vein. It is the first vein to ligate during the surgery. Now you know the anatomy. Now how will you do the investigation? Like if there is a pathology of thyroid gland, then the first investigation you do is TFT. TFT is thyroid function test. The most basic, the most common information you know is that if TSH is low and T3 and T4 are high, it is called hyperthyroidism. If TSH is high and T3 T4 is low, it is called hypothyroidism. So this is the most basic investigation you do in a thyroid pathology. The second one is you can do FNAC. FNAC is fine needle aspiration cytology. Okay, this is a kind of biopsy. Now what is the problem is it cannot differentiate between follicular adenoma versus follicular carcinoma. In next pages you will know why it cannot differentiate. Okay, the second is FNAC, and this is the investigation of choice for any kind of mass or tumor in thyroid. The third is called thyroid scan or RAYU scan. In this is RAYU means radioactive isotope uptake. Okay, so why do we do thyroid scan and what is used in it? We use technetium 99 or iodine 123. What is the indication? The indication is low TSH and high T3 or ectopic tissue. So from the indication you can understand we do this scan to know why there is hyperthyroidism in the body. What is the pathology behind it? Is it because of any kind of ectopic tissue found anywhere else in the body, or then how will you say there will be cold or hot nodule? Cold means that part is not functioning, hot is that part is hyper functioning. There is also ectopic tissue. Now the ectopic tissue which is found in ovary, it is called stroma ovari. Okay, just a one liner, you should remember it. Now what is goiter? So goiter is of two types. Either it can be diffuse or it can be multinodular. Diffuse is physiological goiter. It is due to deficiency in iodine. Now multinodular, it is a pathological condition, and there are multiple nodules in the thyroid gland, and it can go up to mediastinum also. That is the reason the clinical feature is dyspnea, stridor and swelling, and the patient will have Pemberton sign. What do you mean by Pemberton sign? Is when you tell your patient to raise your arm, both of the arms, there will be facial congestion. You can see the facial congestion, the redness on the face. It is called Pemberton sign, and it is found in goiter only. Now you know all the pathology. Now it's time to perform surgery. So how will you perform this surgery? Okay, so surgery, first you need a instrument which is called Joel's thyroid retractor. It keeps the thyroid open. Now the position is rose position. You have to keep the patient in rose position. Why do you keep in the rose position? Because it decreases the venous congestion. Due to that, you get a bloodless field to operate. What incision will you make? You will make a collar incision. The collar incision is 2 finger above suprasternal notch, and this incision is from one sternocleidomastoid to another sternocleidomastoid. Now the how will you remove thyroid gland? So either you do hyomethyroidectomy, half is removed. You can do subtotal thyroidectomy, the lower part is removed. You can do near total thyroidectomy, which is also called as Hartley-Dunhill procedure, where 3/4 is removed, and you can do total thyroidectomy, which is complete thyroid has been removed. Now if you want to do it laparoscopically, then you can do MIVAT, which is called minimal invasive video assisted thyroid surgery. Okay, the most common laparoscopic incision is through transaxillary, and the indication to do laparoscopic is if the tumor is less than 3 cm. What is the most common complication of the thyroid surgery? It is the slippage of ligature, which will cause hemorrhage. The another complication is hypoparathyroidism. As you remember, as I said here, if you will damage inferior thyroid artery, it can create problem in parathyroid also. So suppose if you make any problem in the parathyroid gland, then it will cause hypoparathyroidism, which will decrease the calcium in the blood, due to which there will be hypocalcemia, and there will be 2 physical signs which will be positive, which is one is Swastek sign and another is Tusho sign. In January 2025, Swastek sign question was asked in our paper. Now if there is calcium is very less, then what will you do? If the calcium is less than 8 milligram per deciliter, you can give calcium gluconate, and if there is more than 8 milligram per deciliter, you can give oral calcium. This is the management of hypocalcemia. The another and very important and very dangerous complication is thyroid storm. Now what is thyroid storm? So thyroid storm is there will be clinical feature of sudden tachyarrhythmia, diarrhea, fever, flushing. This is thyroid storm. And how will you manage it? By using 4 P's. 4 P's mean you will use a beta blocker, which is propranolol. You can use PTU. You can use prednisolone, which is a steroid, and you can use potassium iodide, which is also known as Lugol solution. This is the management of thyroid storm, and it is the most complicated and most dangerous complication in thyroid surgery or after thyroid surgery. Now you must have known that why will you remove the thyroid gland? If the thyroid gland is hypofunctioning, then you do not need to remove it. You have to just give thyroxine. You have to give the thyroid hormone to the body. The only reason you will remove the gland is when it is hyperfunctioning and there is a lot of thyroid hormones into the body. That is the reason you have to remove half of it, or whole thyroid gland, or if there is any tumor which also secreting a lot of hormone. So that is the reason we are performing this thyroid surgery. So what will you do after completing thyroid surgery is you will wait for 4 to 6 weeks. You do not give any kind of medication. You will wait, and after 4 to 6 weeks you will do again a Ryu scan. Why you do a Ryu scan? You have to check if there is any recurrence in the symptoms, if there any recurrence in the hormone levels, so that you can understand whether the surgery was successful or not, or whether there is any recurrence, or if we have missed any kind of pathological tissue in the body. So that is the reason you will perform after 4 to 6 weeks a Ryu scan. Now come to the cancer part. Cancer is very important, and this cancer has been asked in surgery also, as well as in medicine also. So there are 4 type of cancers in thyroid, which is papillary, follicular, anaplastic, medullary. And every time there are question from any one of this, or maybe 2 or 3 question. For example, like in my exam January 2025, there were 2 question. One was regarding papillary carcinoma and one was regarding medullary carcinoma. And when I was preparing, in most of the PYQs, this question was repeating and repeating every time. Whether you are solving FMG papers or NEETPG paper, this question will definitely come. So you should master this. And I have made a very small table which has all the high yield point, and these are the question they generally ask. So regarding the cancer is, what are the risk factor? So these are papillary, follicular, anaplastic, medullary. So risk factor is, for papillary it is radiation, follicular is long standing multi nodular goiter, anaplastic is old age, medullary is man 2A and 2B. What are the gene responsible? So for papillary is BRAF, follicular is RAS, anaplastic is P53, and medullary is red gene. What is the spread? So spread is lymphatic, the follicular is hematogenous, anaplastic is local, and medullary is also lymphatic. So now you will understand. See here in follicular, it is only spreaded by hematogenous route. So do you remember when I said that FNAC cannot differentiate between follicular adenoma versus follicular carcinoma? Is because it is spreading by hematogenous route, not by lymphatic route. So if you are going to take a biopsy from a node, then there will be nothing found in that. That is the reason you cannot differentiate on a FNAC. You have to do multiple investigation for follicular carcinoma of thyroid. What is the most common site of metastasis? Is vertebrate in papillary, follicular, anaplastic, and medullary as well. What are the markers? So marker is very important. So thyroglobin is the tumor marker for papillary, follicular, and anaplastic. What is the for medullary? It is calcitonin. Remember this is very frequently asked. Now after surgery, if you want to measure thyroglobulin and you see that it is more than 2 nanogram per ml, that means there is recurrence of the cancer. If you will take the biopsy, what will be the histopathological examination? You can say is, in papillary you will see psammoma body and orphan NEI nuclei. This is asked multiple times. Okay, and in medullary you will see amyloid stroma. What about the prognosis? Which has the best prognosis and which has the worst prognosis? The prognosis is best in papillary carcinoma and the worst is anaplastic carcinoma. In medullary carcinoma, you should always rule out pheochromocytoma. Just it is a one-liner, remember that. What is the most important prognostic factor in thyroid? Is the age. Okay, the most important prognostic factor is age. So here we have finished our thyroid surgery notes. Okay, and this is the very high yield, and this is the basic question they ask in the FMG exam. You, after this, finishing this, try to solve the PYQ of the thyroid. So you will understand what is important, what is not important, and what is multiple asked in FMG exam. So here we have finished it. So guys, again I will remind you that I am putting a lot of effort so that you pass your FMG exam in your very first attempt. So that is the reason you also put some efforts for yourself. Okay, finish this. This is like 3 pages only. It is, you can finish this in 5 minutes. Even before exam, if you are revising it from it, you can finish this in 1 minute. Just scrolling the pages and you can finish this. So it is very important. And next we will start with the GIT, which is the very best topic in the surgery, and most of the question is asked from the GIT. So the notes of this will be in my Telegram group. My Telegram group is Dr. Prince. Also the link will be in the description box. Join this, and all the notes of general surgery, my handwritten note, breast, and all the important high yield points of the FMG exam I have put into my group. So you can join this group and also subscribe to my channel, so you can know all my videos and all my techniques, study technique, due to which I was able to score 174 in 1.5 months of my preparation. And if you not watch my video, watch all this video. Start with the surgery, then ENT also, and next we will start with the GIT. Thank you.